Hello everyone. Welcome to the Total Worker Health Evaluating the Evidence webinar with Dr. Shelley Campo. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships to our organization. As I mentioned, my name's Tanya, and I'll be moderating the session today, and our speaker is Dr. Shelley Campo. Dr. Campo is the Director of Outreach with the Healthier Workforce Center of the Midwest. She's an Associate Professor in the Department of Community and Behavioral Health and in the Department of Communication Studies. Her research and teaching centers on health communication and social marketing. Her work focuses on how to encourage more informed decision-making and to encourage healthy behaviors. Most of her work has focused on reducing risk through identifying and attempting to influence individual, family, and healthcare provider variables that impact behaviors in a wide variety of populations, particularly those with health disparities. And I will hand it over to you now, Shelley.
Well, thank you very much for the lovely introduction, Tanya. I apologize that I'm the fill-in. So the director of the center was unfortunately called to Washington, D.C. We have a little bit of a different background. Hers is more in occupational safety, and mine is actually more on the health side and the communication of health. But I have been involved with the Healthier Workforce Center officially for more than 3 years, and have known about the center and been peripherally involved since it began 10 years ago. So hopefully I'll have enough ability to answer your questions, and what I cannot answer I'm very happy to forward to other people. It's a pleasure for me to do this for Canada. I will say that this concept of total worker health is a relatively new one in the United States, and I'll be talking about that in a bit. I want to introduce the center a little bit. I'm going to talk about what total worker health is. I'm going to talk about some of the research and outreach projects that we do from here, and here in my case is at the University of Iowa. As well as I want to talk a little bit more broadly about what we know about the state of the evidence for this idea and where some of the research and dissemination gaps are. Even though we have somewhat different health systems, I think some of the concepts around total worker health will be highly applicable to both audiences. And I was born on the St. Lawrence Seaway across from Kingston, Ontario, so I think of myself as a near Canadian. About half of our population right now I think would like to be a true Canadian, so we will see how this goes today. I want to say that the mission of the Healthier Workforce Center really is a safety and health mission. We're interested in protecting and preserving worker safety and health, both through knowledge generation, which is really research, as well as translation and dissemination of evidence-based total worker health practices to try to get them adopted by various workplaces. We have been funded by the U.S. national agency called the National Institute for Occupational Safety and Health, which is more of a research and dissemination arm for workplace-related issues. Our compliance arm is OSHA, which is the Occupational Safety and Health Administration. There are currently 6 centers that are funded as part of NIOSH's Total Worker Health Center mission, and until 2 months ago there were only 4. So our newest 2 are one at the University of Illinois at Chicago, and a second one that is now based in Colorado. The other thing that happened is that the center that I'm involved with here was originally only based and primarily focused on the state of Iowa, and we now cover a 4-state region. So we cover Iowa, Kansas, Nebraska, and Missouri. So we're a little bigger than we were 2 months ago. but we do still have sort of a national and to some degree an international interest. So total worker health, sort of at its core, is the protection of workers from work-related hazards, as well as trying to figure out how to prevent injury and illness. And obviously, these two things are interrelated in many, many important ways. You know, if you're injured on the job, that's likely to impact your level of stress, potential, you know, immune system for other kinds of illnesses, potential secondary injuries, etc. As well as, you know, illnesses can impact your safety on the job in terms of the ability to concentrate, etc. So the newest definition from NIOSH around total worker health is, and it changed in the last year. They've become a little bit more holistic in their thinking, but it's about policies, programs, and practices that integrate protection of work-related safety and health hazards with promotion of injury prevention, injury and illness prevention, in order to advance worker well-being. So thinking about the overall health and well-being of the individual, but there is an element of this that also plays into thinking about the health of family and the health of communities as well, because as workers get sick or have injuries, obviously that impacts more than the individual, him or herself. So really, from our standpoint in the Healthier Workforce Center of the Midwest, which started in a Department of Occupational and Environmental Health, we are particularly interested in how workplace factors impact other kinds of health outcomes. So what is it about the nature of work that impacts our overall safety and health? So what about shift work or workplace violence or the feeling that you have related to your decision-making authority in the workplace? People with more autonomy, for example, we know tend to be happier and healthier workplaces. What's your time pressure and workload? You know, what's the availability of affordable child care in your area? And is your workplace helping with that in any way? How physically demanding is the work? What are the wages like in terms of, you know, helping you cope with genuine costs and stresses, as well as any kind of chemical exposures your workplace may have. And you know, with the low wage issue in the U.S., we certainly are seeing increases in number of people who are holding more than one job, for example, which increases risks in other kinds of ways. We know that if there are issues in the workplace that are particularly causing stress, that can actually lead to increases in unhealthy behaviors, and those unhealthy behaviors can then in turn impact your overall health. We also know that there can be some direct impact of those work-related factors, for example, on low back pain, blood pressure, cardiovascular disease, and depression. As I was saying to Tanya, you can't see me, but I'm actually a very small person. So no matter what desk and chair I sit at, and I've got a footstool, I always experience some level of lower back pain just because the workplace is not at all designed for me. And all of these things can in turn impact, can have workplace impacts in terms of how much workers are absent, whether or not, how able they are to focus on their job and be efficient while they're there, which is presenteeism. In the U.S., it has large impacts on insurance rates and insurance claims, and it certainly impacts injury risk. So again, we're talking about that sort of integration of work with thinking about how it relates to injury and illness as well as safety. So I'm going to tell you a little bit about the U.S. first, as you certainly know more about your own provinces. But the Midwest part of the United States is actually a more unsafe place than other parts of the U.S. And part of it may be related to the nature of the kinds of industries we have in the Midwest. So, you know, Iowa in particular is very much like your plains provinces, we have many more rural populations, and we have many more people working in farming, which tends to be a fairly unsafe type of work. So we have been in Iowa concerned about the fact that the injury rates are higher than the national average. And many of our companies and employers within our region are small, and that's important too in the U.S. because if the employer is under 50 employees right now, they do not have to provide health insurance, and we have no socialized medicine system. So that's definitely an issue. We spent about the first 5 years of our 10 years as a center really looking closely to identify the burden of injuries, illnesses, and costs to employers, particularly small employers, as well as to really examine the need for evidence-based low-cost resources, which I'll talk about in a minute. 90% of the businesses in Iowa are actually small businesses, meaning they employ fewer than 250. So we have definitely been examining small businesses, and I'll talk about that a little bit more in a minute. We all know that work can be dangerous, you know, and we've definitely seen improvements to some degree over the last 40 years in workplace injuries in the U.S., but now we're kind of stagnating. And that those injuries that people have economic impacts. They increase our workers' compensation claims and costs, medical expenses, fines and penalties from our compliance agencies. Oops. Decreased productivity, lost days of work, and I'll talk about that a little bit more as it compares to Canada. As well as increases turnover rates, and particularly for small businesses, turnover can be a major problem, particularly if you're rural, because you don't really have an employee base to go after to replace when people are actually leaving their jobs. So the best estimates that we have in the U.S., which are still probably underestimates, are that as of 2007, the costs of work-related injuries and illnesses was at least $250 billion in U.S. dollars. And, you know, that's more than the cost of all cancers combined. It's more than the cost of diabetes and more than the cost of strokes. So the thing about total worker health is it certainly starts by considering what we think of as traditional workplace hazards. These are things like physical, biological, chemical, biomechanical, and safety sorts of hazards. So we definitely need to start there. But there are clearly other threats that are facing workers that you will all understand. You know, we have shift work. We have job demands, we have increasing sedentary work, and commute times in, you know, parts of the U.S. And Canada can be incredibly long. There was a study released in the Annals of Internal Medicine, which was really looking at the impact of sitting, and it found that health hazards were higher for people who sat at least 8 to 9 hours a day. And that sitting for a prolonged period raised cardiovascular risk by 14%, cancer by 13%, and diabetes by 91%. So, you know, there are significant costs to sitting, and in the U.S. they talk about this is the new smoking, that this is really a hazard that we need to begin to figure out how to address better. And certainly for most professions, the workplaces are becoming increasingly sedentary. We spend far more time at the computer. We hardly have to leave a sitting position. And so the amount of what we would call very light work has increased, but things that were more moderate in requirements are decreasing, agricultural work being one of those. So we're down to about 2% of the population that works there. So farm jobs, again, more moderate exercise, but a lot of the sedentary kinds of things are really most jobs. It's 43% of U.S. jobs. The other thing that I want to talk about is I don't know about what's going on in Canada, but in the U.S. there's an awful lot of talk about how much strain the aging workforce is putting on the U.S. economy and on workplaces. But I think that may be true of things like chronic disease, but younger generations have different kinds of health and safety-related risks. So I would just say that one thing to keep in mind is that these are issues that impact the entire lifespan, sometimes in different ways. But we know that our youngest generations of workers in the United States, millennials and Generation Xers, are really experiencing unhealthy levels of stress. And in part, this may be because of instability of the availability of work and other kinds of problems. They're at much higher risk for anxiety, depression, more likely to lay at night than are older workers. And millennials are likely to continue their sedentary behaviors in after hours, sometimes as a way to manage stress and sometimes because they think those things are fun, but they spend a lot of time in the U.S., for example, playing video games, this is not a new problem for young adults, but eating unhealthy food continues to be a problem. The other issue that we struggle with is that work is no longer just 9 to 5, excuse me. And because of that, we don't know when to shut it off. Stress is high. Again, people are sitting more. And the changing demographics of potentially needing multiple jobs is a problem in the U.S. There are a lot more people on temporary or contingent work and more part-time workers. We also, even if we have just a typical job, we tend to work sometimes what seems like all the time. We're checking email, we're checking email when we're at the dinner table, we're checking email when we're out to a restaurant, when we're on an airplane, we're joining, conference calls while doing other kinds of things. So work is not as contained in some ways as it used to be. We also know in the U.S. that we have very high rates of unhealthy lifestyle, what we think of as lifestyle behaviors. Again, some of these may be caused by workplace-related stresses, but the adult binge drinking rate in the U.S. Is about 20%. In the Midwest, it is even higher. And we do not tend to meet physical activity guidelines. We have very high rates of obesity in the U.S. Our smoking and drinking rates tend to be fairly comparable to Canada, but our obesity rates are actually higher. You have more overweight, and we have more that actually qualify as obese. In Canada, and these are from your Workers' Comp Association, but in Canada you see some kinds of similar trends in terms of thinking about the fact that injuries are occurring across the lifespan. They're not limited to older adults, for example. And that's an important thing. We also know that some industries like construction and manufacturing in the U.S. And in Canada tend to have large numbers of injury rate claims. One of the things when I was looking into this that I thought was particularly interesting is that workers' comp claims in Canada, if people took a workers' comp claim on average, they tended to take about 30 days before they returned to the job. In the U.S., it's only 9. I don't suspect it's because the injuries are actually worse. I suspect that the U.S. system does not provide things like sick time and so forth, and people feel compelled to actually have to return to the workplace before they really should be returning. But it's an empirical question. But that is another area where we're different. When we founded the center about 10 years ago, we were interested in sort of both the employer perspective as well as the employee's perspective. And one of the first things we did was a series of statewide surveys, one for each group. And we definitely saw that most employers in the state of Iowa were small. and very financially precarious, and unable, to, for example, to hire their own safety and health experts. So, you know, the CEO or somebody else, their HR person, was in charge of doing those things, but they weren't necessarily trained to do them, which is of concern. We also know in small businesses that injury and illness rates are higher, and those small businesses tend to have no employee health promotion programs. So it makes it hard for them to really consider the impact of the work environment on long-term health outcomes or lifestyle behaviors. And so the burden in this population is particularly hard. And we saw some of the same things reflected in the employee survey, particularly those who are working in smaller businesses. So again, we have a lot of what you would call micro businesses in the state of Iowa. These are employers with fewer than 10 employees. So it can be quite a burden in those places to figure out how you're going to handle safety and health programs beyond what you're required to do by law. Another thing that we've done, particularly since I joined the center leading the outreach efforts, is that we began to conduct an awful lot of site visits with small employers and to really examine what was going on in a range of types of employment. And trying to figure out from their perspective what was possible in terms of actually being able to implement. And clearly one of the things that we found was that they were very interested in these topics, but they were so poorly resourced. They needed really good ideas of things that were quick to implement, off-the-shelf kinds of, activities that could be done, and, really thinking about what would be a low-cost solution that might have some kind of bang for the buck. In the last year, we've moved away. We've moved not only from thinking about more for-profit employers, but we spent a lot of time in municipalities, which are towns, cities, and county kind of employment situations in our region, trying to figure out what's going on with them that makes them a little bit different. And there definitely are some different things about municipalities, particularly in places where city councils and mayors, et cetera, tend to turn over with elections. Because then you almost have to start all over again, particularly if the person knows nothing about safety and health, in order to get them up to speed to be able to support broader kinds of initiatives. As a result of these sorts of visits with small employers, we actually developed 2 interventions that are freely available on our website, and I encourage you to go there and shop around and take anything you want. But we developed 2 video series. The first was what was called Total Worker Health Essentials, which took the sort of the key elements of what a total worker health program should have. First addressing what total worker health is, then addressing sort of the case for small businesses about why they should care about total worker health. Then we talked about the importance of management and employee participation. Then we talked about the basics of designing programs, low-cost solutions, and evaluation. And this 8-part series, the videos tend to range between about 4 and 7 minutes apiece. So even if you watch the whole series, it's under an hour's worth of education and gives some really good ideas about things that people might be able to implement, particularly in small workplaces. Then we also started to hear about topics that employers really wanted to know more about in depth. And so we started that series as well, and we're in the middle of, for example, a video on workplace-related violence, both somebody coming in externally as well as like employee violence and domestic violence situations. With the Total Worker Health Essentials series, we actually primarily used voices from the small employers that we visited. It's more of a peer-on-peer sort of approach, with small businesses that had won awards for safety and health and were innovative in particular ways. And we use them as sort of the spokespeople to make the case for why other small businesses can and should adopt these kinds of things. When we move to the in-depth series, we also combined it, the voices in the videos and the expertise to also include more traditional researchers who were doing cutting-edge work on some of these topics, which are clearly important in workplaces. So again, both series are available on the web. So I would say, you know, what we have seen thus far is that the impact of these interventions in workplaces of various sizes can be that total worker health programs, policies, and practices can impact employee retention, decrease absenteeism, enhance productivity, help with cost maintenance, improve morale, and that's a big issue in small businesses. People feel more connected to other people, and that helps with them staying in retention too. And then it can help improve the health not only of the employees but of their families, who also, again, in small business environments tend to be more engaged with the whole process. There was a study published in the Journal of Environmental Medicine recently that looked at actually large businesses, and these are businesses that are highly successful and are part of what we call the S&P 500, which is one of our major economic indices. These are Fortune 500 companies that we track to see how the economy is doing. And a study with them found that those companies that were both had high health and high safety scores actually were outperforming other companies that were similar to them. So there are real economic reasons for businesses to think about implementing both health and safety, and to think about them together in some way. So all of this adds to sort of the growing evidence that health and safety are important correlates in terms of performance, and have impacts both on the workplaces and on the workers, and that's an important aspect of why I think it's important to consider some of the things that are coming out of this line of research and thinking in your own workplaces. I'm going to turn next, as we move on a little bit, to talk about some of the actual research projects that are also being done in Iowa. But does anybody have any questions to this point? I'm either perfectly clear or completely overwhelming you. All right, I'm going to assume I'm a little bit more on the clear side. I think, you know, one of the great things about total worker health is that it makes intuitive sense, in social science that we would call that high face validity, that we really do understand that health and safety are intimately intertwined, and the more we can do to address and think about both simultaneously, the better off workplaces are, and so are the population that we are trying to protect. One of the research projects that we've been working on at the University of Iowa for the last 5 years, which is being led by Dr. Nate Fethke, who's an engineer and an ergonomist, is trying to figure out whether or not technology that was developed by the Virtual Soldier program, which is a digital human modeling software that was developed in order to predict sort of movement, posture, and other functions in a real-time environment, and then could layer on real-world constraints, muscle fatigue, carrying needs. It could consider gender, body size, clothing restrictions, etc., to try to figure out how to better design equipment for soldiers, and what the physical limitations were, and how to work around them so that soldiers avoided injury. And what he was interested in doing in part was examining whether or not the same technology could be used in manufacturing environments to try to identify workplace potential workplace hazards based on the populations they had working in various places, and what adjustments could be made to the workplaces themselves to actually impact their safety. And ultimately, we hope, we're still waiting on the data from workers' compensation claims, but to really impact the numbers of and types of injuries, the severity of injuries, et cetera, of these workers. So the intervention sort of included two parts, actually. The one was really about using this avatar system to figure out the ergonomics and then go back to the company and help them make changes that would reduce the risk of injuries. The second was to embed people to help employees work on health topics that were of importance to them. And we did this in three ways. There were facility-wide events. There were needs assessments to figure out what health topics people were really interested in, stress being a leading one. But we also provided free health coaching using motivational interviewing on site to help people sort of, work through their issues, and to look at whether or not the combination of these two things actually, again, improved health and safety outcomes. So, and it was done with a window manufacturer who's based both in Iowa and Ohio. So one was an intervention site and one was a comparison site. And again, the preliminary data are actually pretty promising, and we hope to have more data available on this soon. So one of the examples in how this worked in the manufacturing plant was to consider, for example, body size and whether or not overweight workers in manufacturing were experiencing different levels of risk to those of more appropriate weight. And so they compared a healthy adult male with a body mass index of about 19 to an overweight, actually in this case an obese male, and then looked at strength and mobility and compared them. So they looked at 100 individuals who had normal BMI weights and 100 who did not in this particular work environment. And then they looked at them doing various tasks, walking with the window, lifting and placing windows at two different heights, which is kind of important. And again, what they found was that the overweight folks had more issues with spinal compression than those who were of healthy weight, and this required some design changes in order to try to minimize that spinal compression problem. Another project that we're working on at Iowa, and this is a project that is now just getting underway, and it's occurring both at the University of Iowa and at Washington University in St. Louis. They're looking at construction workers, and they're more importantly looking at apprentice construction workers. So in the U.S., many construction workers start as apprentices, are trained, and then kind of work their way up through the system. And it's a really good time to do intervention, because if we can get them doing safer and healthier things early, then hopefully that will carry on throughout their career. We know that construction is far more unsafe than other kinds of places. We know that unemployment rates can be higher, and that's stressful. And we also know that smokers compared to other, or workers in construction compared to other kinds of industries really are much more likely to smoke. So again, the national average in the U.S. among adults is about 20%, but in construction it's almost a third of construction workers. So that is of concern. And especially if they're actually smoking on the job, because then that also becomes a safety hazard for them and for others around them. All right, any questions on those two projects?
I don't see any questions yet, Shelley.
All right, there's 71 of you out there, so, you know, at some point you have to speak up. The next thing I want to talk about, in addition, these are two of our larger projects that have and are going on, but the center has provided 18 pilot awards in small grants to new investigators, to graduate students, and in what we call also community grants. To have them investigate as well as disseminate and translate total worker health ideas, and then evaluate the outcomes of those. The research projects have mostly been intervention oriented, but the center funds everything from more basic research all the way through translation. And these have occurred in a number of different kinds of environments. We've looked at law enforcement and corrections officers. And law enforcement officers, as you may or may not know, are more likely to be sedentary, more likely to be obese, and more likely to eat in very unhealthy ways. They also have, you know, somewhat crazy hours. That is all. Some of those things also carry over to healthcare workers in various kinds of settings who have irregular kinds of shifts. We have looked at air quality in restaurants as well as noise quality in restaurants during rush and other times, and the impact on hearing. There have been projects about small businesses, impact of retail grocery workers on lifting, for example. We've had a number of studies looking at sedentary behavior. We had a really interesting project looking at workplace violence issues. But the outcomes from these grants have been really good. We've provided testimony to task forces in Washington, D.C. That have been convened by the President. We've been in more than 100 different media outlets with these projects. They've resulted in lots of publications. And they have resulted in true changes in workplaces in really important ways. I had asked whether or not I could pitch this all to you in terms of, we still have a pilot grant program, whether or not you can apply out of the U.S. And apparently the answer is only with special permission, so I can't actually encourage you to participate, although I really think it would be great if some of these studies started being done in other environments. So I've talked a little bit about what we've found in our own center. And now I want to talk about what's the state of the evidence for total worker health, because this is a relatively new idea in the United States. You know, it's less than 10 years old. And there have been two very important events that have occurred since December of last year. The first is that last December, the National Institutes of Health convened what they called the Pathways to Prevention Workshop on Total Worker Health to sort of examine what they thought was going on with total worker health, where the gaps were, what we needed to know, etc. This was a task force mostly of very senior scientists, including the dean of my own College of Public Health, who actually chaired that committee. But there were people from occupational safety and health backgrounds really trying to examine what was going on. And then the Agency for Healthcare Research and Quality, which is another healthcare agency, and the research head was somebody who actually was a physician who used to work in Toronto at the University of Toronto. She actually convened another group of researchers to do a systematic review of the state of total worker health and to figure out whether or not it was having better, worse, or different outcomes than things that were not total worker health. There are some things that are in common about these two reports, and they're both publicly available. The NIH one was published recently in the Annals of Internal Medicine, but it's also available on NIH's Total Worker Health website. And the AHRQ one is also, again, available online in a number of different places. and both of them are free. So I encourage you to look. The AHRQ one in particular really lays out every single study that's been done and what the outcomes were. So the NIH group basically concluded that research on what they call integrated interventions is sparse and unclear. And I think in part this is actually an issue with the definition of what total worker health is. So it is supposed to be the integration of health and safety. But what does it actually mean to be integrated? Does that mean you have both a health and a safety program? Does it mean that the same people are involved in both? Does it mean when you put in a safety program you also think about the health outcomes as part of your evaluation plan, or the reverse? And you can imagine that this is particularly the difference between a small and a large company, that this could look like a whole lot of different things. And so one of the issues to me is what actually qualifies as integrated, and how much integration do you really need to actually have an impact? We don't have a good sense of that right now. We also don't have a good handle on whether or not there are not only benefits of potential integration, but are there potential harms? And this is an issue that has been talked about to some degree. So in a small company, it's not unusual, as I indicated, for the same person to be handling both safety and health, partially just by default. So that would be integrated in some meaningful way. But the odds are good that the person is not equally an expert in both safety and health, which sounds to me like somebody is being, one side of this might be short-shifted, and that's not necessarily a good thing. I'm not sure that we want, safety people of large organizations, people with industrial hygiene programs running our wellness programs, for example, or the reverse. So, but I do think there is a really good need for those groups of individuals to work in a more collaborative fashion and to understand that what the other is doing is having an impact on their area as well. So, for example, if somebody's in really good physical condition, the time for them to recover, if they should have an injury, is going to be substantially less than for somebody who is not as well, and that's an important consideration. What they did find was that the interventions that were integrated, that were more multi-component, complex, and had really good dissemination plans to encourage adoption, were more effective than those that were not. And they made some recommendations. They thought that that a group of researchers, a larger group of researchers, needed to be convened to really help set research priorities, as well as to figure out methods to approach those. And in fact, actually, that meeting is likely to be held at the University of Iowa in March. We need a more consensus-based conceptual framework to guide these kinds of research activities. Where possible, more common measures and outcomes need to be considered so that it's easier for us to compare across studies. We need more transdisciplinary and participatory processes for intervention development. One of the strengths we really have at Iowa compared to some other institutions is that the faculty who are involved with the center really are diverse. My PhD is in communication, with somebody else from engineering, another person from industrial hygiene, an occupational med doc, a psychologist, an anthropologist, etc. And so I think the involvement of that different number of fields, and we really collaborate with each other well, provides some insight and some innovation in some important ways. We do need a wider range of methods being used, and both qualitative and quantitative, and done in more rigorous ways. But studies in real-world environments are tricky for lots of reasons, and so that's going to be a limitation for a while. We definitely need a better idea of getting this stuff disseminated to a range of stakeholders more quickly and efficiently. This is an area as a communication person I'm particularly interested in. And we need more financial investments in research to try to figure all this out and where it actually works. The AHRQ document really started by trying to identify every study that had ever been done on that might be potentially related to total worker health. And they really considered that what was going on was that there were a number of studies looking at what happens in these. You have a group of employed adults, you apply some kind of integrated intervention. In the short term, you tend to see outcomes that are behavioral, or they might be drops in intermediary kind of things like blood pressure drops or cholesterol drops. And you might see more near misses or fewer near misses, hopefully, in these cases. And then ultimately what you're trying to see is far less workplace injury, far less depression and anxiety, far less stress, etc. But again, those require much longer term kinds of studies than what we have to date. And so they started with a review of the literature, and they looked for anything basically related to workplace health and safety that might have some kind of total worker health focus. And they started with 1,625 articles that they identified as potentially meeting the definition of total worker health. But when they looked at all these things in more depth, what they really found were 24 articles that were really eligible to include in a systematic review. So again, the state of the published evidence on this is very small. And those 24 studies were very heterogeneous with respect to work setting, populations, the type of interventions done, and outcomes. We also know that most of the workers involved in those studies were between the ages of 30 and 50. Few had really looked at baseline health status and medical mortality and morbidity issues, which is important. And few studies really described very well what the safety and health promotion programs were at those workplaces at baseline. So there are potentially other confounds there that are not being addressed. So the first question they looked at was around the effectiveness and harms of interventions. They did not believe that the studies provided enough data to draw conclusions. So they said, you know, we need a lot more work in this area to figure this out. In terms of the components of effective interventions, worker participation was extremely important. So they need to be involved in the development, the design, planning, and implementation of all of these kinds of programs. And we know that more participatory approaches are more likely to lead to worker buy-in and therefore participation. They'll feel a stake, they'll feel embedded, and more like they're being listened to. And hopefully, too, then the design of those really reflect the needs and wants of the particular work population, and that's important as well. Most of these interventions were tailored to the cultural and social aspects of that particular population and workplace. And all were multi-component and complex interventions that used a wide range of ways to communicate complex health messages over time to really try to impact behavior. There are contextual issues that may matter in regards to whether or not total worker health practices matter. One is related to some organizational factors. Size of the organization, structure of the organization. We talk to small businesses, for example, that are 3-shift kinds of places, but because of how they run, for example, their health promotion programs, the 3rd shift people never see any of those things. So that can be an organizational factor that impacts participation in those kinds of employee programs. Union membership may matter in important ways because depending on how the union feels about these programs, whether or not they've participated in their development, etc., they may or may not encourage their employees to participate. And there are probably lots of other possibilities. In the U.S., health insurance status is a big concern. We have no federal health insurance that guarantees everybody basic rights to health care. Access to primary care, particularly in rural populations, is a big problem. I apologize. I'm going to try to unplug my phone. You know, employee stress, organizational changes, etc., can also impact outcomes. So we've got a lot of research gaps to fill in terms of looking at work settings and populations. I believe there are a lot of them around what does integration mean, and what does it mean with different populations and workplace settings, and how do we best maximize that, again, to get the most bang for our buck out of the synergy between health and safety. We need more comparison groups as we're doing these studies, and we don't really know that much yet about longer term outcomes, which I think are really vital. And in addition to everything else on this slide, as the NIH report also pointed out, we need some more rigorous methods that use a range of methods, really look qualitatively and quantitatively about the various problems, and then try to figure out exactly what's going on in these cases so that we can design even better interventions in the future. So that's sort of it in a nutshell. We've got about 8 more minutes. I'm happy to try to address questions or to refer you to individuals who can address them even better than I can.
Let's see, Shelley, there are a couple. Any evidence on leadership models that improve/influence total worker health?
We know that leadership buy-in is critical. But the type of leader, I'm not sure that we know if it matters. We do know that, for example, in small businesses, leaders who really also model and participate in the programs that are designed, who are highly visible, who not only talk the talk but walk the walk. We know from qualitative research that we've done that can matter an awful lot. It also can matter from the standpoint of really investing resources and time and allowing their people to participate as well, and I think that's critical. But whether or not you're a more participatory or hierarchical leader, I'm not sure that, like, for example, I don't know what the impact of that kind of leadership style would make. But I do think that the top management really participating and buying in is critical.
All right, and then another person asking, can you give us ideas on specific TWH programs that have been implemented with small businesses?
We have a whole lot of them actually available through the video series, so I encourage you to look at particularly the one that's about low-cost solutions. And there's some really great ideas there. There's some very low-cost kinds of things like just having much better workplace policies around health and safety behaviors, better kinds of training around those issues, particularly around the safety issues, to try to impact outcomes in a better way. Having health and safety committees at least meet together, or their leaderships meet together at least a few times a year to coordinate efforts and exchange information about what they're learning is important. Particularly because the source of the problem might not be what one person thinks, it could be something else entirely. So it would be good to know, for example, if they completely changed up the work schedule and that was actually what was leading to the safety problems as opposed to, you know, some other aspect. But if you weren't aware of that in another unit, you might not know to adjust for those kinds of things. So do check out the video on low-cost solutions, and I think you'll find a number from small businesses that talking about their own implemented programs. But you know, there's a small business about 25 miles north of here that made health and safety part of its own mission statement, even though it has absolutely nothing to do with the with what the industry is. But but they wanted to make it front and center about how important those issues are to them, that, you know, they have engraved it on the wall, and it's, you know, on basically every piece of paper that comes out of the agency.
All right. And then could you share some challenges with sustainability of the program and how those challenges have been overcome?
So policy and training solutions can often be more sustainable. Changes to equipment might also be more sustainable if there is money to invest in upfront costs. What's harder, I think, is more of the health-related programming that's solely health-related, because a lot of the health promotion things in small businesses tend to be around things like challenges, you know, weight challenges around holidays and those kinds of things. And they aren't necessarily, people get excited about them for 6 or 8 weeks, but then they go away. There's some debate in the literature about incentivizing those and thinking about, you know, low incentives, like a little bit of a discount on something or some points back, or a little bit of extra money can be good, but too much in incentives can be bad, because then people say they only made the change long enough to get the incentive and then they stop.
All right. And then final question. Someone was asking, they thought that you said there would be videos on violence in the workplace coming soon on the Total Work.
There will be one coming soon. We have footage, but we have not finished the production of that video. But we've been interested in, it may actually end up being 2 or 3 videos, but we have some footage talking about sort of training efforts. We have in smaller businesses, as well as sort of environmental changes with counter heights and those kinds of things. But it's also thinking about 3 different types of violence: worker on worker, you know, the domestic violence situation, or the stranger sort of walking in, you know. And that could either be random or, you know, an unhappy customer, for example.
Okay, great. I think that's all the questions we had. Thank you very much, Shelley, for the presentation and for the introduction and overview of kind of what total worker health is and what you at your center is really kind of diving into. That's very interesting.
Well, I appreciate being asked to do it, and please feel free to contact us if there's more questions or things that we can do for you.